So we are slightly shifting now the focus, and we're going to talk about females. And some of the information that you heard in the first talk were very useful to introduce this next talk on females. And you heard already that in families where there is an affected individual with Duchenne muscular dystrophy or dystrophinopathy, the mothers, the females in the family may be carriers. And generally speaking, we believe that about 2/3 of mothers of a male with dystrophinopathy would carry the DMD mutation. And as you can see here, I don't know if you can see, so you can see that females would carry 2 copies, one working copy of the gene indicated in green and a non-working copy of the gene. And they would therefore be carriers. Now, however, as you heard already, there are sometimes situations where females can be carrier of the gene but not have family history or not have anybody in the family with the male affected. And therefore, the female could be the first person in the family who is identified to carry the gene. What is the prevalence in the population of females who carry mutation in the DMD gene? The numbers indicate are relatively low, and there have been analyses both of females who are completely asymptomatic or females who have raised creatine kinase, and the numbers indicate a relatively low percentage, 0.002% of the population studied. However, we believe that this is probably an underestimate. We don't really know the real prevalence in the general population of females who carry a variant in the dystrophin gene. This is also because the majority of females don't have any symptoms, so why would you test them if they don't have family history? And the lack of symptoms is both on clinical examination, on cardiac testing, or any laboratory testing. CK may not be elevated. And data shows that CK is actually probably elevated only in part of females, roughly estimated to be about 50%, but these numbers may be not correct. Why is that females don't have symptoms if they carry a dystrophin gene variant? You heard it already, because females have 2 copies of the X chromosome, one that is working that compensates for the fact that there is a copy that is not working, and this is why only males usually show symptoms. However, sometimes females can show symptoms, and Teresa has mentioned some of the reasons why this may happen. Sorry, there's a bit of shift of the title, and may develop symptoms of dystrophinopathy. And again, how many females would have symptoms? Again, there are some numbers available from literature, but this is probably not the real reality or real estimation of symptomatology. And generally, we say that about 10% of females who carry mutation would show some symptoms in their lifetime. However, again, I think probably these numbers may be slightly an underestimate. What could be the symptoms that they present if they do show symptoms? Could be one of these or a combination of these symptoms. So could have raised creatine kinase, you could have muscle weakness, who could be variably progressive or stable. You could have muscle hypertrophy, like for example, you have larger calves. It could be also asymmetric, so you might see that not both legs are similarly hypertrophic. You might have aches and pains, cardiac involvement. You may have sometimes central nervous system involvement, maybe cognitive difficulties, developmental delay. And then on muscle biopsy, you may see symptoms of lack of reduction of dystrophin and immunostaining. And this may be non-uniform, so you might see a patchy distribution of dystrophin in your cells. How do you do diagnosis and say that a female is symptomatic and has symptoms of dystrophinopathy? This is a clinical diagnosis and is made really by the clinician who assesses the patient and the lady with the symptoms based on the identification clearly of a pathogenic variant in the dystrophin gene and presence of symptoms. Now, again, thinking about all the symptoms, this can be quite variable. As I said, this age at onset of symptom can be variable. It may be early age, but there are also females who have been reported with presentation later in life. Majority of ladies who present symptom have muscle weakness, but also myalgia, muscle cramps are so common. And as we said before, the symptoms can be very asymmetric. You can see in these pictures of the MRI of the legs how the involvement of muscle, adipose tissue in the muscle is very asymmetric. You are much more relevant here than in this picture here. The presence of a mutation that leads to Becker or Duchenne muscular dystrophy is irrelevant. We don't see that that is the reason why somebody shows or not symptoms. Again, you might have difference in severity, but the presence of clinical findings is not often depending on the type of mutation. We know that there is also possible central nervous system involvement in some females, but the prevalence of this has been studied in some cohort of individuals, but is not probably fully understood. Now, we also don't really know what is the influence of age on symptoms. Does age affect the onset of symptoms? Would symptoms get worse over time or not? We really don't know this fully yet. There have been case series that are being now published, but if you look into literature, there are not that many large cohorts of individuals described. There are a few papers in the last 2 decades, and there are more additional case series that are being described now. And there is, for example, this case series that Professor Quillivan has indicated from London. And as you can see, the symptoms are quite variable. Some individuals had early onset, some later, and some were ambulant, some non. Some were treated with steroid, others haven't been during their lifetime. And you can see also the presence of cardiomyopathy. Cardiomyopathy is probably one of the most relevant things that females are informed about when they know that they are carriers, and the lifetime risk of cardiomyopathy has been estimated to be up to 60%, but other, for example, data published papers on symptomatic carrier or non-symptomatic carrier indicate that this to be probably higher than that. The aged onset or diagnosis of cardiomyopathy is usually later in life. Usually the symptoms, however, only are observed and evident when the ventricular dysfunction is much more advanced. Apologies, because there have been quite a lot of issues with how the slides look like. They were not like this on my computer, apologies. And also there has been evidence that perhaps during pregnancy, some of the cardiac features and severity can change. So that is something to keep in mind. From a genetic point of view, clearly to be a dystrophin carriers, females have to carry a change, and this change has to be pathogenic. So let's not forget that there are changes in a gene that do not cause a disease. So the variant that the female carry has to be a pathogenic variant. The genetic changes that females carry are very different. So we have genetic heterogeneity. So as you heard before from the previous talk, there are many, many different changes. And again, females may carry any of these: deletions, duplications, point mutations, frame shift variants. There has been some evidence that perhaps in some population there are higher prevalence of deletions or small variants. So this probably may indicate the distribution that maybe some variants are more common in some of this population. And you heard already before, there might be also females who carry 2 changes, one on one chromosome, and then you have a second variant on the second chromosome and be compound heterozygous. You also heard about the concept of X chromosome inactivation before as one of the reasons why females may be symptomatic. And this is something I wanted to just explain a little bit more. So we know that females have 2 X chromosomes, but in general, in nature, there is a mechanism called X chromosome inactivation that prevents having a lethal mixed messaging when if both chromosomes were active. So clearly, if all females were having 2 working chromosomes, we would have an additional whole chromosome more than males. And this would not be okay. So we have to inactivate one of these 2 chromosomes randomly. And what happens is that when we are conceived and when we are born, and so during our fetal life, one of the 2 X chromosomes are inactivated. And this is random. It might be either one or the other. And this makes us a sort of a mosaic of cells. In some cells, one X chromosome inactivated, in some other is another one. Now, what happens if this X chromosome has there is a gene that encodes for something, okay? In this case, for example, we are looking at the color of the fur of this cat, okay? So sometimes the inactivated X is the one that makes the fur orange. Sometimes is the X chromosome that makes the fur black, and then you become patchy, a mixed mosaic, like in the cat. Clearly, the color of your fur doesn't affect the health of the cat in this case. But what happens if the gene that you are inactivating, the X that you're inactivating, has a gene that has a change that causes a disease? You are depending if your inactivation is random, 50-50, you are healthy. But if the inactivation is not random, it's skewed, so you inactivate more the X chromosome that does have the working chromosome, you would have a situation where you have more cells expressing the disease gene, and therefore you would be symptomatic. So you would have a situation where you are highly skewed, basically only the disease genes being expressed, and then you are affected by the disease. And this is what we think that could happen in females, and it has been studied that X inactivation could be abnormal, not random, and therefore highly skewed. However, again, we know something, but not everything. And we know that most women generally would have a random inactivation, and some females in the population may have skewed inactivation. We know that X inactivation can correlate, the level can be similar between blood and tissue, but what you really want to know is the inactivation in muscle, and this is something that we wouldn't do routinely. And also, we believe that X inactivation changes with time, and they are now with age. So your X inactivation would be different when you're born as a girl or when you're older. And also, it appears that X inactivation might also depend on the time in over periods. So it looks that females who were born 20, 30 years ago have different levels of X inactivation compared to today. So maybe there's an environmental influence as well. So there's a lot of things that we don't know. Yeah, so there is quite a lot that we still need to learn, and I think the literature information that we have, it's contradictory. Perhaps also how we test X inactivation might affect this. So overall, we believe that probably there is some effect of X inactivation on the severity of symptom, but the correlation is not 100% clear. So if you, for example, look into this, it is quite small, but there are, for example, here you can see that there was 100 to 0, so complete skewed inactivation. You would expect quite a severe presentation in this lady. In fact, the symptoms were Duchenne-like. But then again, if you look at these others, we have 100-0 with a mutation that is expected to cause dystrophinopathy. But this patient was walking well, and symptoms were a little milder. Or here, for example, where you have 90 to 10, 17 years old and walking. So the X inactivation not always 100% tells you the severity of the symptoms. So there are a lot of things that we know, a lot of things that we still don't know well, and together with the colleagues that are listed here, Professor Fellini from Italy, Professor Quillivan from London, and Dr. Burke from Newcastle, we felt that there were quite a lot of information that we wanted to gather better to understand in what is the real clinical phenotype in females who have or no symptoms, how to define carrier status, and what is the best way to assess females, and how to provide care for them. So we decided 2 years ago to set up a workshop, one of these ENMC workshops you might have heard about, where experts of conditions sit together and think about how to improve knowledge, care, and treatment for a disease or a group of patients. So we did this last year, and some of the colleagues, including Michela Aguilera is also here, who have been met in this meeting and run through all these questions. So first of all, we started asking ourselves, and Elizabeth Room from Duchenne, the World Duchenne Organization, arranged a service, first of all, to ask, what are the services, for example, that female carriers want and expect for themselves? So what they said is that they would like to have regular physical checkup, psychological support, counseling, and regular cardiac care. However, if you look at what was available, again, apologies for this misalignment, this was only available in much less than the numbers of the ladies who said that they want this. So that shows that actually the care and the support they need is not always available. They would like to have genetic testing, possibly earlier than what is currently offered, and psychological support should be really offered, whatever, if they are affected or not. And females should be assessed and managed in their own right, rather than in the context of being the mother of somebody who has a disease. And this is a very important concept. And there is a huge variability of services that are offered to females, and sometimes they are not even aware what are the services that they can access. And this is something that we often hear when we see families in clinic. The other thing that has been mentioned is also that may be relevant for other countries, not so much the UK, but the definition of being carrier or affected carrier is important for your insurance, that can be relevant in some countries, and the distinction between symptomatic and non-symptomatic really does affect the diagnosis and the care that you are provided with. So that is very important. We did a similar survey in Europe, and Dr. Teresina Evangelista from the EuronMD network has led on this, and we asked again some questions about what is the care that patients receive, and some answers were quite important. So if you see, for example, only a very small number of individuals attend specialized neuromuscular service, only half of them have cardiological assessment, and not all of them had genetic counseling. So you really would expect that this should be done by majority of the female carriers. We also ask clinicians who look after patients and females, and most clinicians feel that clinical review and cardiac assessment is important, and surveillance should not be stopped. So in summary, this survey really told us that only a part of responders have the care that they should have, and really it's important to continue symptom management. So then if we have to think about symptom management, how should we do this? Should we guide the care like we do in males? Like, think about, should we do it like with disease progression? Should the care that we offer be different between those females who are symptomatic compared to the symptomatic females? So just do carrier testing when they're 16, when they are symptomatic, and then start cardiac screening. If they're symptomatic, should we offer them the same treatments and care like males? Or should the asymptomatic females have any other additional monitoring? And what is the assessment tools that we should use in female carrier? Should we use the North Star? But the North Star assessment might not be good for them. Maybe they would be too functionally able to do those tests. Should we offer steroids? And if we should, what age, when, how long, what type of steroids? Should we consider other drugs? Could female carriers access clinical trials if there are gene therapy or disease-modifying therapies? We don't have natural history studies or registries. So we felt that we have a lot of answer to question to answer for, but we had some recommendations in that setting that we thought it would be useful. First of all, these are my last few slides, we should improve the definition and forget, if possible, some terms that were used in the past, and we recommended some terms that we have, we are just put it there, but we doesn't, we understand that these have to be agreed upon worldwide. We would prefer to use the term carrier or DMD gene variant or DMD carrier for females who do not have symptoms, but when they are symptomatic, we can use the term patient with dystrophinopathy. You can then subclassify patient with skeletal dystrophinopathy or cardiac dystrophinopathy if you want, and really avoid the term manifesting carrier because these may create confusion. And again, it's important that the females are treated in their own right. It's important that we offer genetic counseling to all females at least after the age of 16. X inactivation has we have to understand how much should or not be done, but the age of 16 is arbitrary. If you have a female who, for example, is thinking about pregnancy, or if the female has symptoms, really we should consider testing earlier in order to set up treatment and care. And really, I would like to highlight the psychological support for DMD carriers, not only at time of diagnosis, but also to help them in this emotionally charged process when they also have to think about informing at-risk female relatives in the family. And please remember that, as we said before, non-being a carrier still have the possibility for a female to be a germline mosaic. Then it's important that we offer neuromuscular follow-up to all females who are confirmed to be carrier, to be sure that they don't have any symptoms, so at least have one-off neuromuscular assessment with a CK and refer to cardiologist. And then, if all normal, discuss if or not the female should continue to be seen by neurologists, but at least continue cardiology assessment. And if there are symptoms, then clearly you have to start thinking about setting up a management plan for them with the multidisciplinary approach. Cardiac care, there are other talks on cardiac care in this setting, but just remember that females do need cardiac surveillance, and this has to be done at baseline shortly after the diagnosis carrier, and then continue according to the recent standards of care that have been more outlined by this recent paper of Dr. John Burke, and I'm just going a bit quicker here for sake of time. Really to prevent progression of cardiac function and deterioration. Finally, it's important that we think about increasing awareness, in particular about the cardiac risk that may occur in females. It's really important that we improve the education of females to make sure that they access cardiac care and monitoring, and make sure that also the clinicians are able to support female carriers in the right way. And for these advocacy groups, like Action Duchenne or other advocacy group, really can help us to increase awareness so that females are aware of the importance that they have to take care of their health as well in order to, to make sure that they remain healthy and well. And we feel that also raising awareness of these topics, for example, in this setting, can help in this process. So, in summary, I hope that this short talk can help you to highlight that talking about female carriers is important. There's quite a lot of things that unfortunately have not yet been met for this group of individuals, and I think that we hope that we can work towards a better definition of what is a DMD carrier and a female with a dystrophinopathy. We need to have better clinical outcomes measures and assessment tools, and we hope that we can improve the management of all the symptoms that females can present, and we hope that all female carriers will have genetic counseling and testing offered, and this should be really done at least at the age of 16 or earlier in case of symptom. And we would hope that we can all improve psychological support for female carriers. And we hope that from now on we can all together help to increase awareness between a patient organization and clinicians about the importance of monitoring females and the importance of develop standards of care, think about natural history studies, set up registries for this patient group in order that we can actually ultimately help the treatment and care. And that was my last slide. I would like to acknowledge all the people and colleagues who were at the NMC workshop, but of course also all the patient families and the community involved in this. Thank you.